Okay, well, we are ready. So we'll take
Wonderful.
it down so you can start, and I'm hoping Tomas is here too. Right.
Yes,
Tomas?
I'm here. I'm here.
Okay.
Um, well, thank you everyone for joining us. I want to welcome you to a previously unscheduled meeting of the Community Vaccine Advisory Committee. And I'm very, very grateful to all of you for you pausing and whatever you're doing in your incredibly busy days to join us for a conversation to respond to an emerging issue that we wanted to make sure to share with you, bring you into the loop, keep you all up to speed, and communicate the latest update to you, and then also get your feedback and your thoughts. So thank you so much for being available. And the purpose of this meeting is to update and respond to some late breaking information coming out of the federal government and the CDC in regards to vaccine and vaccine prioritization. And so I will allow my co-host today, the role of Dr. Erica Pan will be played by Dr. Tomas Aragon, and Dr. Aragon will co-host the meeting and also help to share some of this information. But before we dive into the meat and potatoes of the meeting, I want to first give Dr. Aragon an opportunity to welcome everyone, and then we'll jump into Bobby reminding us about the rules and the guidelines for the meeting.
Good afternoon, everyone. Thank you so much for taking time out of your day on such short notice to come here and participate. Things are happening so fast in the country, in California, the hospital surge, the infections, the deaths that are happening. So we're in a real critical time right now, because while things are getting worse, we know we have vaccine supply that's going to be getting better. With the changes in administration, we expect more vaccines to become available. So this morning, it was announced from the federal government that the CDC will be coming out with guidelines to prioritize age in terms of getting the vaccine. The two key things that will be coming out is one is to prioritize vaccinating people who are greater than 65, and also part of the guideline will be vaccinating people with medical conditions if they're between the ages of 16 to 65. We haven't seen the specific guidelines yet. California was already moving in this direction to focus or prioritize older age groups. And one of the reasons why this is important, it doesn't mean that we would be not prioritizing the other groups, but what I want to emphasize is right now with a hospital surge, the vast majority of patients that are being hospitalized are older persons, and also the ICU admissions and the deaths are happening with older persons. And we have to also recognize that the majority of persons who end up in the hospitals are people who are highly impacted. So primarily Latinos, African Americans, low income, persons from the highest impacted communities are the ones who are in the hospital. So the way that we're going to impact the surge is by lifting and prioritizing the older age groups. And the other thing that happens is that when the hospital systems are this impacted, when you're going into surge, when you're canceling other procedures, when you're reducing access, it impacts the whole community. Everybody's impacted when you can't access medical care because of the surge. So this is a really important area. And we want to do it in a way that honors all the hard work that's already been done, the development of the framework, the phases, the tiers, and how can we do it in a way that's very simple. And the Surgeon General said earlier, simplicity saves lives. So that's what we want to do. I'm going to go ahead and stop there because I know folks are going to go ahead and introduce some of the discussion that's happening, some of the framework and how we're thinking about it. So I'm going to turn it back to Dr. Burke Harris so she can go ahead and move us forward. Again, thank you so much.
Thank you so much, Dr. Aragon. And Bobby, if you could walk us through the meeting guidelines just to start us off.
Great, thank you. And thank you from me to all of you for just changing your entire schedule for this afternoon and being with us. I just want to remind everybody a few things. The hand raise icon has now moved to the reactions section of your toolbar. So when you're ready to make comments, which I know you will be, please find it there. I want to thank our 2 ASL interpreters who on very short notice also joined us. Vicki Kennedy, they've been with us for all of our last meetings, and we're very happy to have them. The public is listening both in English and Spanish on the call-in telephone line, and also the live stream is up and running. Just so you know, at our last meeting, we had over 2,000 individuals viewing the live stream. Public comments are welcome. We will not be presenting a summary of public comments today since the meeting was called on short notice, but we do have a meeting next Wednesday, January 20th, and public comments will be summarized and presented at that meeting. And again, for members of the advisory committee, if you have any technical questions with Zoom, if you put them in our chat, we will do our best to help you navigate the Zoom platform. So thank you, Dr. Burke Harris.
Thank you so much, Bobby. And if we move forward with the slides, I think we've already made some opening comments. So we'll jump right into the proposal that we are asking, that we are presenting today. Which is, as you heard previously from Dr. Aragon, the CDC, we heard today that the CDC has a plan to prioritize people and place a greater priority on age in terms of who is getting access to the vaccine. So immediately before this meeting, we had a meeting with the drafting guidelines work group to think about how do we want to incorporate and update our current recommendations in light of the upcoming CDC guidance. And I'm just going to check in here really quickly. Bobby, did you want Dr. Schechter to present this information, or should I go ahead and present it?
Well, I think maybe if the two of you could do it together, it would be great. So Rob, would you like to start, or would you like Dr. Burke Harris to start?
Oh, thanks, Bobby. Can you hear me okay?
Yeah, we can hear you great.
I'm happy to tag team in any way with Dr. Burke Harris. I'll have her. How about she can start, and I'll go through the main details.
Great. And, Dr. Burke Harris, Dr. Brooks is also on the line also.
Oh, wonderful, wonderful. So if you all will remember, and looking at the proposal that is listed here, if you all will remember, this looks very, very similar to our slide of the plan for for moving forward with phase 1B. The difference here is that where it says 65 plus years, previously it said 75 plus years, right? And what is being proposed today is to expand tier 1 of phase 1B to include those who are 65 and older, right? So to include that, and then we would continue to have, there would be no change in the prioritized sectors in terms of food and ag, education, and our first responders. And as we think about the implementation, some of the implementation considerations that we would like our vaccinators to keep in mind would be thinking about, if we're moving swiftly, vaccinating folks, and we certainly have, enough vaccine, then there would be no issue of further subprioritization. However, if counties or vaccinators are seeing a potential of inadequate supply, really thinking about prioritizing those who are older, so those who are 75 plus, before those who are in the 65 to 74 range. I see that the slide says 64 to 75, but I know that it's 65 to 74. And then also prioritizing our vulnerable communities, those who are at greater risk, whether it's based on the Healthy Places Index or another social vulnerability index. And then in addition, for those who have the capacity, right? So if it's feasible, then also prioritizing those with underlying medical conditions. And part of the reason why I say, for those who have the capacity or if it's feasible, is that many of you may be aware of, and we talked about in our last meeting, the state really pushing to ramp up and have some of these larger vaccination events so that we can really get doses in arms. And that has been the priority. The governor has charged us with that mandate, and that is something that we are implementing. So as we're seeing some of these larger mass vaccination sites, it may be more challenging in those settings for the vaccinators to be confirming a medical history if they're not in the patient's medical home, or they don't have access to the medical record. So that's the reason why it says underlying medical conditions that increase risk as feasible. And Rob, is there anything that I missed or anything you want to add?
I think that's the basic outline. Well done.
And there's one other piece that I want to add, which is that what we understand in terms of the guidance from the CDC was the guidance focused on prioritizing older individuals, those 65 and older. And then also there was guidance around prioritizing those 16 through 64 with underlying medical conditions that increase risk of severe COVID-19. Currently, in our current phase tiers system, those individuals are in phase 1C. And at this time, the drafting guidelines work group agreed that it makes sense to continue to leave that group in phase 1C, for the reason being that when we look at the numbers currently, it would be roughly an additional potentially 10 to 15 million individuals. And if that group were added, so when we think about expanding phase 1B to add an additional 15 million to what is currently already 8.5 million, and bumping up with those 65 and older to be increased further, then that becomes really an implementation challenge, right? And so we're looking at just in terms of the sheer numbers, maintaining that 16 to 65 with underlying health condition that increase risk of severe COVID-19, particularly in light of the data that shows that currently with the surge, the individuals that are most likely to be hospitalized, those who are really limiting our hospital capacity, still continue to be our older Californians, those who are 65 and older. And so I'll pause there and give an opportunity for Dr. Aragon or Dr. Schechter to add any additional comments.
Dr. Burke-Harris, this is Rob Schechter again. I just want to point out a typo in the slide, which is...
Yeah, there's a few mistakes on the slides. The wrong slide is picked up here, Rob.
Okay.
I can make the suggested changes, or you can say them, and then I'll fix them while we're talking.
Yeah, so apologies, given a reflection of not the thought that went into it, but the pace in our working today. That as I think is pointed out in the chat, the congregate settings refers to other tiers and not to this tier. So tier 1B remains an age-based group plus the 3 occupational sectors, but not the congregate settings within tier 1. And as well as the numerical typo that Dr. Burke-Harris mentioned about the ages. So apologies, and hope that's clear.
Yeah, I'm going to try to fix those right now. But give me just
So this is Dr. Aragon. I do not have any additional comments at this time. The summary was fantastic.
So at this point, I see that we have a number of questions in the chat, and we want to open up the conversation. I see hands are being raised as we speak. So I think we can go ahead and jump into a conversation about this. And I'm not, Bobby, I will leave it to you in terms of calling out the chat versus the questions in the chat versus the hands raised.
Yeah. Yeah, I'm just trying to do too many things here at once, and I don't want to disconnect the Zoom. So just give me 1 second, please.
While you're working on that, Bobby, I noticed that one question in the chat is underlying medical conditions still defined solely through the CDC list of comorbidities? And I want to answer that to say, it is through the CDC list of conditions that increase the risk of severe COVID-19. Obviously, we're talking about access to the COVID-19 vaccine, right? So when we're looking at the criteria is the list of conditions that increase the risk for severe COVID-19 disease.
Okay, so here we go. I apologize for that delay. Let's start with Anthony Wright, and then we'll go to Denny Chan, and then Mary McCune, and then Dr. Tong, and then we'll keep it up.
Thank you. I expect to go first, but first of all, thank you for your work and the quick response and the opportunity to comment. It is noteworthy that actually California had actually been moving toward age-based approaches, and something that I think we thought was compelling based on both ICU use and the need to reduce that, as well as equity between seniors and different types of facilities, and just the clarity and simplicity that it provides to the public for knowing where they stand. I think. So I'm generally in favor of this of this movement and prioritization. To the extent that we're all this is a very tough conversation about trade-offs. And from the slides from earlier sessions, this indicates that adding a 65 plus category seems to add 3.5 million people. If it was my calculation from earlier slides, is that right? And is there, do we have what is our sense? It's hard to make this decision without any sense of either the logistical operations to be able to support that increased amount, or what we expect the supply to come in over whenever this will be triggered on. And then if that's the case, then how do we do this, these prioritization? I will just say that, I had my 83-year-old mom lives in New York. I actually signed her up for a vaccine this weekend, and I had to go through like an online form and uploading documents and things that my mom, would not have been able to do by herself. And I just want to just understand how we are going to deal with making sure that we're taking care in a not only culturally but technologically competent way to the population that we want to get vaccinated. Thank you.
I can try and fill in a couple of those blanks. The addition of the 65 plus, in addition to the 65 through 74, in addition to 75 plus, it's probably around 4.25 million Californians. And the pace of vaccine at this point appears to be somewhere in the range of 2 million doses for California in January. We've heard mixed messages from the federal government about when supplies might increase, whether that's by the end of this month or into next month. And then with additional vaccine formulations possibly to follow. So for the addition of the 4 million does mean weeks to months of additional vaccine.
Okay, thank you, Rob. And that was Anthony Wright from Health Access. So so that members of the public watching know who's speaking. Let's go to Denny Chan.
Thanks, Bobby. Hi, everyone. Happy New Year. Denny Chan from Justice in Neighborhood. I wanted to, first of all, say thank you for pulling this meeting together to get our input on relooking at what 1B might look like, and appreciate the speed with which everyone is acting. As advocates for older adults, we generally are supportive of using age as a criteria and figuring out what the allocation mechanisms or a framework would look like. I will say that, if we're thinking about high-risk people, and when we made the decision as a state to prioritize people in long-term care facilities, we really need to make sure that, to some of the comments that have already been said in the chat, that we are exhausting that before we really get to 1B. We've heard of a number of issues in this meeting and other places where smaller long-term care facilities just aren't getting the shots. And whether that's because of the partnership issues or other issues, it really needs to be considered before we even start talking about people in the community. So I would really urge sort of greater attention there. And on the issue of risk, a number of the CVAC members did write to the drafting guidelines committee to say that, we really hope that the state will take seriously a recommendation to prioritize home and community-based services users. This is a known population of the state. It is a high-risk population. There are people who, but for the HCBS they're receiving, would be in a nursing facility where they would get the shot under 1A. And I think it's just a very compelling, and including that population would in no means sort of balloon the figure to some of the numbers that were said earlier. I think it's still a much more manageable number. The state has these people's information. And so it's a very small universe of people who, when we're thinking about risk and we're thinking about who really needs those shots, when we're thinking about equity, these are all low-income people who are on this program. This is an opportunity for, people to not be divided by age or disability or condition. And this is really an opportunity where we can use sort of a known universe of people and prioritize them based on sort of the risk that they have. So thank you.
Thank you, Denny, for your comments. Let's go on to Mary McCune. Mary, don't forget to introduce yourself.
Hi, everyone. I'm Mary McCune, and I'm with the California Dental Association. And for right now, I think I really want to urge the committee to focus on flexibility with this. What we've seen with phase 1A is that we've collapsed all these tiers for a couple different reasons, but it also allows flexibility for these points of distribution to just get everyone who wants the vaccine and can get there in time to get there. So that way we kind of keep these two goals paramount, one of which is vaccinating the vaccinator, but the other one, which I think will spill over into phase 1B, is not letting any doses go unwasted. And as I'm looking at this list right here, I'm looking at food and ag, I'm looking at folks 65 and older, that if we're able to get them and their families vaccinated at the same time, I think the local health departments and whatever future pods we're able to set up to give them the flexibility to not turn away those folks, because if they're there and we have the shots there, then they should be able to get vaccinated, and it will help kind of speed along that process.
Thank you, Mary, for that. As we go to Dr. Tan, after Dr. Tan, we'll go to Dr. Wasserman, and then we'll go to Andy, and then we'll go to Susan tomorrow. Go ahead, Dr. Tan.
Thank you, Bobby. This is Henry Tan, Chief Diversity Officer at UC Davis Health, and also representing the CMA. I really appreciate the responsiveness that the state and colleagues are working on this. I just want to say and lend my support to the prioritization of vulnerable communities using a place-based index. We talked about that last week, and it's wonderful to see that that is being included in the criteria.
Yes, you're running for healthcare workers. We just wanted to make sure. It just seems like, well, in our experience, last week, there are a lot of people that aren't in the phases. And
Everyone, please mute their line.
Wanted to make sure when it gets opened up to pharmacists beyond healthcare workers that we haven't.
Okay, Dr. Tan, unmute yourself.
Thank you, Bobby. I just wanted to just emphasize again that you know, with vulnerable communities, I think that they don't necessarily fit into the tier system, and so incorporating a place-based index, as we've talked about last week, is so critical. I think it's also really important to keep in mind the longitudinal perspective, particularly with vulnerable communities, since because of the historical barriers that you know, vulnerable and minoritized communities may not actively seek out vaccinations because of fears and other structural barriers. And so by proactively identifying communities using a place-based index, we can be more proactively and tailor our outreach to the communities, and thereby improve in the long-term trust with these communities. That said, I think that as we prioritize vulnerable communities, we may not actually see them come to the infrastructure that we build. That's not a sign that we should give up. It's a sign that we need to just move in the direction of building trust. And so it needs to start early and need to be sustained throughout this process. So thank you very much for the opportunity to speak.
Thank you, Dr. Tan. We'll go to Mike Wasserman now, and then we'll go to Andy.
So Mike Wasserman, California Association of Long-Term Care Medicine. You know, I served on the National Academy Committee, and there was a reason we put nursing homes, assisted livings, and group homes together. Not only the residents, but the frontline staff. And the data shows people who work in those settings have been working in the most dangerous job in the country for the last 10 months. So the challenge has been not just making the prioritization, and this has become painfully clear. For the last 3 months, CalTCM has convened a group of subject matter experts looking at this, and what has happened has been very predictable. The problem right now, we've been delayed in getting the nursing homes vaccinated, but even more concerning is the assisted living facilities and group homes, not only for older adults, but for the disabled community who live in a lot of these facilities as well, are at risk of being left behind in our haste to get the vaccine out to everyone else. And so what we put out a list of recommendations and shared them with the vaccine task force last week. This has all been a problem at the federal level. They rolled this out the wrong way. They got CVS and Walgreens to be responsible. They had no business doing that. If we want to get all the residents and a large number of the staff in nursing homes, assisted livings, and group homes vaccinated, we must immediately engage all of the long-term care pharmacies, all of the pharmacies out there that can work with in collaboration with CVS and Walgreens. This is not about anyone's making money or anyone's market share. This has to be about all hands on deck, getting the vaccine into the arms of those people who live in nursing homes, assisted living, group homes, and the people who care for them. And I'll add one specialized category. People with Alzheimer's disease don't wear their masks. They don't physically distance. You can't keep them in their rooms. The vaccine is the only thing we have for them. And many of those live in assisted living facilities, memory care units, group homes, and nursing homes. Right now, there are assisted living facilities that are not signed up to get the vaccine till March. And there are many assisted living facilities that aren't even signed up yet. That is completely unacceptable. It's not our fault that this ended up this way, but we have no choice but to fix it because the federal government didn't put us in a position to get it right. I think the state is ready to do this. I think once we get those folks vaccinated, then I'm willing to talk about all the other categories because these are the folks who have been dying. 2,200 people died last month alone in long-term care in the state of California.
So just a minute, Dr. Wasserman, I'm sorry, I don't mean to interrupt you, but I do want to clarify the intent of your statement. Yep. Because is your statement a concern about adding those 65 to 74 to Tier 1B, or is your statement more a state of concern about the implementation of Phase 1A?
So actually, it's a great question. I don't want perfection to be the enemy of the good here. What I am worried about is if we don't make sure that we're vaccinating the folks at highest risk, we'll get the other folks vaccinated and we will continue to have people die who are at the greatest risk. So my focus is let's make sure we're doing that right. And we can chew gum and walk at the same time and use the other vaccines that are still available beyond nursing homes, assisted livings, and group homes to go to other phases.
Yeah, I want to be clear that just because the focus of this meeting is to attend to and address and update all of you and seek your input on the feedback around the emerging CDC guidelines and the notion of the state of California adding 65 plus to Tier 1B does not mean that we're abandoning our commitment to thoughtfully and effectively implementing our vaccination strategy for Tier 1A. I agree with you that we can walk and chew gum at the same time. And but the thing that I want to make sure that for the purpose of this conversation and to ensure that this is that as folks share their input, that there's not a perception that we're abandoning our current system. And there were a couple, I want to speak to it because there are a couple of questions in the chat of, does this mean that California is moving away from a priority system? Does this mean that we, where are we in the tiers right now? And I want to respond briefly to some of those questions in terms of where we are right now is that everyone is in Phase 1A, right? Every county is in Phase 1A right now, and different counties and different facilities have different capacity in terms of their ability to move to Phase 1B. And so some are ready and rearing to go, and some are still well within the process and really working out some of the challenges to implementing Phase 1A, right? And learning from that process. And so that is where we are. To speak to some of the questions in the chat, but I also just want to assure you that we're working together to solve multiple challenges at the same time, including surge, including our working on our different tiers of planning for vaccine allocation, and this is what we're doing. So
thank you, Dr. Burke-Harris, and thank you, Dr. Wasserman, for your comments as always. Let's go on to Andy. Andy, don't forget to introduce yourself, please, and then we'll go to Susan.
Sure. Hi, Andy Imparato with Disability Rights of California. You know, I want to support what Denny said. Dr. Burke-Harris, I recognize that none of this is straightforward or easy, but the sense that I have is the feds told us to place a higher priority on people over 65 and people 16 to 64 who are at severe risk of bad consequences from COVID. And we decided to leave the 16 to 64-year-olds in 1C because it's 10 to 15 million people. So I guess my question is, can we find a subpopulation of 16 to 64-year-olds in the state who clearly have equity concerns related to access to healthcare, related to being forced to interact with direct support workers who may or may not be you know, wearing masks and socially distancing, and get services to a subpopulation of in-home supportive services recipients or regional center clients. Those are two very discrete populations that we can identify. And to me, the analysis is similar to the Healthy Places Index. These are populations that historically do not have access to quality healthcare, are at increased risk of severe consequences of COVID. We don't have great data on their health risk because they're not studied, and that, you know, we shouldn't be punished for the fact that the medical field does not do a good job tracking how these things affect people with intellectual disabilities. So I really want to urge you to think about, is there a subpopulation of folks with disabilities who belong in Tier 1, Phase 1B, under vulnerable communities using HPI or equivalent, or underlying medical conditions that increase risk as feasible? For IHSS and for regional center, it's much more feasible because we know who these people are, we know where they live, and we know how to get the vaccine to them.
thank you.
Thank you, Andy. We'll go to Susan, and then after Susan, we'll go to Deborah Shade, Brianna, and then Charles Bakke.
Hi, this is Susan DeMorris with the Alzheimer's Association. And one thing that our state's doing exceptionally well is tracking data. And as of today, 75% of all fatalities in our state have been 65 and older. So this direction, you know, we support this direction. Age is also the greatest risk factor for Alzheimer's disease. And when you take it down to the next level of data that we collect, 50 to 64, that's 94% of all fatalities in our state. And we heard earlier about hospitalizations and ICU use. And so I haven't seen the slide that shows the age breakdown there, but I think we've been hearing that it's risk, exposure, and equity is what we've been hearing this week, the risk of an adverse or fatality, a fatal outcome. The question that I have is, when we expand to 65 plus, as the chat indicates, that's millions of new Californians, what is the pathway, keeping it simple with our messaging and communication? People are contacting public health departments that are already overwhelmed, and they're contacting their physician while we're trying to offload the healthcare system. So how can we advise people on where they should get started about a vaccine when it opens up to an additional few million people when they read this in the newspaper?
Great question. Rob, do you think you could answer that question, or Tomas?
Yeah, I'll go ahead and just get started. Thank you for the question. It's a really important question. I'm sure Dr. Schechter will be able to add more to this. Right now, we're in the process of building up the IT systems, the information technology systems. This is just going to be part of the answer, but we need to have a way where people can have access to the information and be able to know how they're going to be vaccinated. So this is in the works right now. So that's one area. The other important area is going to be working with the health systems. The health systems do have the capacity through electronic health records to really be able to reach people very quickly in terms of age and in terms of medical conditions. The other area that we're also working on is doing targeted outreach. For us to really address the equity issues, it's not going to be sufficient to depend on the health systems, even on the megapods, because there are a lot of parts of California that if we don't go out and do the community outreach, we're not going to reach those populations. And so those are areas that we do have to work on so that we can do that right. It's going to really take the partnerships with the local health departments and communities to really make that happen. So let me start with that and see if Rob has anything else that he can add to my initial comments.
So again, I apologize, but if I can just ask you to make sure I'm answering all the parts of your question.
Rob, does that mean you want Susan to repeat her questions?
Yes, please.
Okay, go for it, Susan.
All right, sure. So when we add a couple additional million people, 65 and older, the questions we've been receiving at the Alzheimer's Association is, do I contact my doctor? Will I be notified? Do I go to my county public health department? Should I drive to one of the mega sites? And we don't know where people should get started. And so any direction about where they begin? Will they get an inbound contact from their physician, whether it's Medi-Cal, Medicare, commercial insurance, or are they expected to take an outbound action to find the vaccine for themselves? There will be a lot of questions, and people are calling their public health departments and their doctors and not, maybe they're calling the wrong place.
So thank you again for repeating the question. And at the moment, it will require more effort, and that effort by your constituency and by persons to locate. But increasingly through the automated tool, Dr. Aragon is described that the state is working on some similar local solutions, outreach by health plans, appointment systems by health systems, online appointment mechanisms. And there'll be increasing capacity over the next weeks for individuals to more quickly and easily get those answers about when and where, and to make those appointments. But now there is a burden on individuals to reach out to their providers and the health departments for often scarce doses.
If I can jump in, if it's helpful, and Dr. Schechter, tell me if I'm getting anything wrong. But what we'd like to do, I think the goal is to make it as easy as possible for folks to be able to get access to the vaccine, right? And so what that means, and that it means that it's not going to be one. It's oftentimes not going to be one simple system for every single person. So for example, folks who we know from talking with the leaders at large health systems like Kaiser and Sutter, that they are prepared to head into phase 1B by notifying people when, especially if there's an age-based system, right? Everyone date of birth before X, notify the patient, oh, Kaiser has the vaccine, Sutter has the vaccine, we can, it's your time to come in and get the vaccine, right? But clearly that system's not going to work for folks who don't have a healthcare home, so we want to make available these large megapods where, anyone can come and get access and sign up and get their shot. Similarly, I think that there are going to be some circumstances for example, more vulnerable communities that are harder to reach, where the Department of Public Health is going to be doing the outreach and in some cases, partnering, as we talked about, partnering with community-based organizations to let individuals or groups know that it's their opportunity, their access to the vaccine, right? And so, although the answer doesn't sound simple, the goal there is to have the process for the individual to be as simple, as seamless as possible. Is that helpful?
It is helpful. I think on our Vaccinate 58, it will be very customized by location. And I think also people, some of the older adults, I'm thinking, specifically to the Alzheimer's community, may not be physically able to go to one of the mega sites or comfortable going to those venues because of the spread of COVID, depending who's accompanying them.
I think increasingly there'll be diversification, not only with the big pods, but more and more routine sources of care as access points as well. And again, over time, opportunity to, likely in more than one site to find vaccine.
Thank you. I know it's a work in progress. I know.
Thank you for taking us along here. So let's go to Deborah and then Brianna and then Charles. And then I know we have a number of other people who would like to speak, and I think I have all of you.
Deborah Shade here, representing the California School Board Association. So I think I understand the simplicity of 65 and older. I think that's what we were trying to achieve with our CARES Act, money to families that needed it without having you submit forms that you have to get it. I think we need to have a similar complex, but when you put additional 4.2 million into the next round and then add sub-prioritizations to it, the complexity in that model is really, I think there will be, if not the same, but more issues as we start to expand this. So I'm just curious about some of the effort that could be done to expand that group into the, I think we're talking, 11, 12 million for that group now. Am I right? I'm trying to get the number right. And then how are those doses going to come in? And then if you're prioritizing within that group, then people are going to get kicked out of that group or get later. I mean, we're talking a very complex system. So if anybody can respond to those two sort of areas, because in approving this, I just want to ensure clearly I want education to be able to get vaccinated so that we can, continue educating our youth. But I understand the issues with age and how they are affecting our, our health system.
So Deborah, that's a great question. I will, Dr. Aragon or Dr. Schechter, if you want to jump in, I will start by simply saying it's part of the conversation. What we understand is that for some counties and some sites, right, we want to vaccinate as many people as possible. We want to, and we've established a prioritization system that's focused on those who are most vulnerable and the likelihood of being hospitalized and the risk of overwhelming our healthcare system, right? And so that's the part of the reason for that age-based prioritization. But we also want to allow enough flexibility so that we are ensuring that doses aren't wasted, right? And so we want to get those doses in arms and at the same time, so we're having a kind of a prioritized tiered system, but at the same time, making sure that we're not so rigid that we are potentially letting certain doses go to waste. And that's what we're hearing in terms of conversation with our local health jurisdictions. And so for that reason, that's the reason why what you see is it's a kind of a very straightforward guidelines to everyone, which is here's tier 1 of phase 1B. It's 65 plus these 3 sectors, right? And then the next part is if you are facing if you are facing significant restrictions on further restrictions on the number of vaccines, if you really don't have enough and you are looking at how do we sub-prioritize, right? Then here are the guidelines of how to do that, right? And so that is something that's going to be very difficult to do if you are in a megapod and you're at Dodger Stadium, and so that's not where that's going to happen. But if you're in a small county and you have limited doses, you can say, okay, we are in this phase and we are prioritizing those 75 plus because we just have a very limited supply of vaccine. And so that's the way that guidance is intended. Dr. Schechter or Dr. Aragon, do you want to add anything to that, or?
Yeah, no, you spoke to it very well. And you know what I heard from the health systems and the health, when we presented this in an earlier meeting, the health systems immediately said, we're ready to do this. We can do this without a problem. We just need more vaccine. And so that was really the rate limiting step. And so it's one of these situations where we want to plan with the assumption that eventually there's going to be a lot of vaccine coming. So we don't want to be in a situation where all of a sudden we have a lot of vaccine and we can't get it out. So, and we want to make sure that we address the issue of the highest risk hospitalization, ICUs, and deaths, and the impact that has on society in general. And so the feedback that we got is the first system is too complicated. It's slowing us down. Keep it simple. Simplicity is going to save lives, and be prepared for a vaccine supply chain that's going to get better and better and better. And we're not going to be, when we start working with these different sector groups, we're not going to be able to verify, different people. It's going to have to be the honor system. And so, but what we absolutely have to get right is getting age, because that one's the easiest one. That one's the easiest one to do.
Dr. Burke-Harris, may I add one word then? Also, I want to keep the group focused. This is an emergency meeting we're having right now, and the whole reason is that the landscape has changed, and it's because we're in a surge where the people that are dying are 65 and up, and then the federal government made some changes. So. And the last thing is that there's not enough vaccine. So we had 300 million doses and 300 million people. We could all be right now shopping online. But since this happened, literally today, and the surge happened more or less since the beginning, let's say, of the year, we're in uncharted territory. So we really would like to get everyone vaccinated and as quickly as possible. But we have people dying at 40,000 a day, I think I heard, in the country. I mean, that's mind-boggling. So that's why we're having this meeting. That's why there will be some areas that won't get it exactly the way they want it, but we have to just have a degree of understanding, and I'll also say compromise.
Thank you, Dr. Brooks. Let's go on to Brianna and then Charles, and then we'll go to Carol Green.
Sure, thank you. Brianna with LHCC, representing the local nonprofit Medi-Cal Health Plan. So I think in every conversation we've had, I've asked questions about logistics. And where we are today is exactly why. So we, on the payer side, have been sitting here with the information that's needed to reach people. and watching it a little bit in panic of we know how to find 65 and older. We know how to identify people with comorbidities and conditions. We know how to slice and dice the data to get to the populations that need it the most. I think to Dr. Edagon's point, the delivery system does this every day, and we're ready and we're willing, and it's been waiting for that green light and a signal to go do what we can do and what we do the best. So I think that this approach and loosening it up so that we can get out there and get shots in people's arms is absolutely the right thing to do. You know, focusing on this population, I think someone else said it meets the risk. You know, it meets the risk where it is. It's an equity lens between the payers. You know, individuals 65 and older, I would presume, are in Medicare. There's a payer source, there's a data source to find them. Comorbidities, payer source, provider data. Just from a practical perspective, this is an approach that we can get out there and maybe we can show some success that will build credibility and will build more support if we're able to get out there and show that we can do this. The other thing I would add is, from a Medi-Cal plan perspective, a Medi-Cal lens is an equity lens. So I think once we get there, that would be terrific.
Thank you. I would just like to remind everybody, if you could keep your comments as succinct and to whatever point you're trying to make. There are a number of members who'd like to comment, and we want to make sure everybody that wants to comment gets a chance. We'll go to Charles, and then we'll go to Carol Green, and then after Carol, we'll go to Kieran.
Thanks, Bobby. Can you hear me okay?
Right.
Great, thank you. Appreciate the work everybody's put in and all the comments that have been so thoughtful, both in the chat box and verbally here. I want to agree with Anthony Wright from Health Access's initial comments at the beginning that, you know, this is kind of where we were headed. You know, it's a slight acceleration. But to Dr. Burke Harris's comments and my colleague at LHPC, Brianna, as representing the California Association of Health Plans, I forgot to say at the beginning, this age-based approach is doable, and the data is there. It's been said, and so I think this is much more in the wheelhouse. I think where a lot of concern was the focus on picking apart all the different definitions of essential workers, which is data that we didn't have. So I do think that this approach makes sense, but I also want to be sensitive to those who are concerned about being left behind. And I also think that, you know, as we're looking at speeding up the distribution of this vaccine through channels that are going to be faster, it's really important in listening to everybody on this advisory committee to not lose sight of the logistical work that has to be done to reach these harder populations. And so I just think that's the uncertainty you're hearing from a lot of people on the call. If I can summarize it, is sure, you're hitting the gas pedal, but don't leave us behind. And I think, you know, you as public officials and experts can help us, and certainly to the extent that we can help, you know, with this, reaching out to these tough populations, difficult to reach populations, we just can't lose sight of that. And I think that's what you're hearing. So thank you.
Thank you, Charles. Let's go to Carol. Don't forget to introduce yourself, and then we'll go to Kieran and then to Jody.
Hi, Carol Green with California State PTA. Just a couple of comments. I hope that in this new plan, we're not going to lose sight of those essential workers that we were talking about, because age is certainly an easier way to get people in and through the lines quickly. But if we have those people that have been also working in the grocery stores, they're not, you know, the medical workers, but the grocery store workers, teachers and educators, if we want to get kids back in school, and you know, the first responders that aren't medical, those we've identified. Let's remember, the only problem is that when you add this big group of people, then you end up with not enough vaccines. I want to tell you that while I've been on this call, I just received a text from a friend and colleague of mine who lost his father to COVID. I mean, just now. So I'm just sharing that with you, because we're talking about real people and real lives and not just numbers. So I just want to share that. The other comment I have is about equity. I live in San Diego County. We opened Petco Park. Folks lined up. It was 1A, it was medical workers. But I had a conversation with my husband while that was going on. There are medical workers that have cars, that can get transportation, that can be there. What about those that don't have cars? What about this next group when, let's not forget about the people that are less economically able. And I think someone mentioned helping his mom at the beginning get through this. When we open it up to 65, there are people that are sharper and faster. They're going to get on the technology. They have a car. They're going to get in line first. So let's remember our equity lens as we go through this. Thank you very much.
Thank you, Carol.
Thank you, Carol. I just want to speak to that because there are a number of comments in the chat as well. And in fact, this is something that we just talked about with the drafting guidelines work group about how we can increase our scale, get those shots in arms, and at the same time hold a very strong equity lens. And so that is something that we are working on. And it's something that I think that hopefully we'll be able to present more information to you at our next meeting. But we are definitely actively in process in really thinking about how do we operationalize some of these strategies for equity. So thank you.
Thank you, Carol. Okay, Karen, and then Jody, and then after Jody, we'll go to Aaron Carruthers.
Thanks, Bobby. This is Karen Savage, California Pan-Ethnic Health Network, and I actually appreciate the comments that Dr. Burke-Harris just made, which go to, I think, one of my 2 points. I mean, I am concerned hearing the governor talk again about Cal Expo, which is where we started off a lot of the testing in Sacramento, and we missed really large segments of our community, and we missed our low-income community of colors when we did that. And so I'm concerned that we not repeat the mistakes we made with testing and end up waiting months before we really get into those communities. And so I appreciate Dr. Burke-Harris hearing that I know there is a lot of thought going into that. I appreciate that we'll be hearing about it soon. I think the other piece that concerns me is pushing down the congregate living settings more with adding the additional prioritization on age. And I'm really concerned about our state prisons. And I understand we've been doing some vaccinating in our prison health centers, the 3, but very concerned about the remaining prisons. And I had a question that I had submitted after the last meeting asking whether people who meet the age criteria who are in our state prisons will be getting vaccinated in this phase, or whether they will have to wait until we get to prisons. We do have an aging population in our prisons who is very sick, who has been dying. And I really would urge us to bump that up. It's also not hard to do. People are all in one place. Goes without saying, these are not people who can go to Cal Expo to get vaccinated. So I really hope we can put some more priority and emphasis on that population.
Thank you, Karen. Tomas, could you comment on the issue of the older aged prisoners and others in state hospitals who are in this age group?
Yeah, so that's a really good question. I was on a call this morning with the staff in correctional facilities who are actually working on this issue, and they do have they have what is called a risk score, and they're very happy to hear about the focus on age. So yes, absolutely, and that's one thing that's good about the issue of age. It can be applied universally across all different sectors, including correctional facilities.
Thank you. Okay, let's go on to Jody and then Aaron, and then after Aaron, we'll go to Mitch Steiger.
Thank you. Jody Hicks, representing Planned Parenthood Affiliates of California, and I echo a lot of what everyone has said in terms of equity and reaching vulnerable communities, which has been the concern. I think what I want to add, and again, simplifying and adding 65 to this group is a good one. Any flexibility is good. I think one of the things I would say is as we move into implementation and looking at looking through an equity lens and getting at vulnerable communities, it's really important to first acknowledge that for an implementation for those communities to work, we have to acknowledge that the structure we have in place right now is not one that lends to an equitable access to care, and all of the barriers that those communities face in terms of access to care are not going away for this vaccine. There isn't some magic vaccinators that are there and ready to go and in those communities. And so health centers like ours that serve those communities, that serve mostly Medi-Cal, mostly Black and Brown communities, tend to be under-resourced. We don't have electronic health records that can parse out who's a farm worker and who's a grocery worker. We do know, though, that the communities we serve are vulnerable for all of the reasons that we know that they are, whether it's housing, lots of essential workers. So we know with a broad stroke, we can move into, we know where the hotspots are and we know where those communities are, and really trying to, and we know, folks that again are serving a lot of Medi-Cal patients. And so I think if we can be flexible, and I know there's more to come on how we're going to do this in a broad manner for this population, but being flexible, resourcing the folks that are already in the community and doing that community outreach and are trusted messengers, and being able to just go community by community, I think is the best way that we can get at a broader population through an equity lens and get as many shots done as possible, and not try and have a list that we all want to be perfect, but then we're not implementing it in a way that's ensuring that we're keeping people safe.
Thank you, Jody. Let's go on to Aaron, and then we'll go to Mitch, and then we'll go to Matt, and then we'll go to Orville, and then Heather.
Thank you, Bob. Thank you, Burke. This is Aaron Carruthers with the State Council on Development of Disabilities. Thank you, Dr. Burke Harris, and thank you, Dr. Aragon, for your quick, fast action today in response to what came out of the CDC and the federal government. Thank you so much for pulling us together, and thank you for the opportunity to give feedback on the redrafted Tier 1 Phase 1B. Thank you for finding a way to carry over from our last meeting to find a way to put the equity index into this phase and this tier. I think that's very effective. Also regarding the underlying medical conditions, building off of what Denny has said, what Andy has said, there's a pretty easy way to operationalize some of the bigger impact for people with disabilities who would be impacted by the underlying medical conditions, and that is to incorporate people who are receiving HCPS services. We wouldn't have to change anything here in the tiers as it's written, just as the way it's clarified and implemented. That number is much smaller than 1 million. That million number that we gave you actually includes people who are 16 and younger. So that's probably the biggest number on the outside. And so just wanted to see and ask whether or not there's any thought to include that and operationalize it under who's considered under the description of underlying medical conditions.
Dr. Schechter, do you have any comment on that? I don't know the answer to that question.
We'll certainly take it into consideration and balancing the overall health risks, the specific health risks of developing severe COVID-19 disease, and the numbers that you mentioned, and trying to balance all those factors. So appreciate the comment and the concerns.
Yeah, I think that what would be required would be a comparison between that list and the estimated number of individuals that have a condition that is listed on the CDC guidelines as significantly increasing the risk for a severe COVID, right? And so I think that's something that is certainly, within the CDPH team can do and look and see what is the actual numbers there. So we're happy to do that.
Okay, thank you, as always, for a very thoughtful comment. Let's go on to Mitch Steiger. Mitch, don't forget to introduce yourself.
Thank you. Mitch Steiger with the California Labor Federation. And as labor representatives, this is an incredibly difficult conversation for us to have, given that, as others have mentioned, moving millions of people farther ahead in line by definition means millions of others are farther back in line. And we represent a lot of those people. Probably most of them are essential workers. And so it's much easier to have this conversation among us on a Zoom call than it is to look one of those workers in the eye and say, you're going to have to get it later. You've already sacrificed everything to keep society functioning during this crisis, and now you're going to have to wait even longer. And so, but given that, the arguments in favor of this are very compelling, and they make a lot of sense. But looking at those two competing directions, we're not really in a position to wholeheartedly support or oppose this idea. We just kind of wanted to make a comment that it's really important, we think, that if we are going to have this change in it, where we do push workers further back in line, that the rest of the system really needs to work as well as it possibly can. So for example, if workers are asked to move back, but then they also see wildly differing approaches from one county to another, it's going to just really compound their skepticism of this whole system. Or if they aren't able to find out where the vaccine distribution sites are, if any of these other concerns do come to fruition, it's going to be really heightened if we're also asking millions of these workers to move back in line. And so we would just really urge, again, as many have said, some sort of a statewide system, real clear requirements or direction to counties that this is how it happens. As much clarity as we can have online in terms of accountability and knowing how many doses have gone out, what are we doing to get them out to people, that if the rest of the system is functioning well and functioning smoothly, it'll be a lot easier for workers to swallow having to move back in line. And just one final point, that we do keep reading about some of these situations that happen where there are excess doses and there's this scramble to get them to people before they expire. Totally understand, like, sometimes that can't be avoided, but maybe one way, if there is any way to target those doses to people, those workers that do have to move back in line would be, we would argue, a good candidate to be first in line for those excess doses, given that they are making this sacrifice. If we do go ahead with this plan, that they are making this sacrifice for the greater good.
Mitch, thank you so much for that comment. And I just want to add that this is some of the difficulty in having this conversation. This is a very difficult conversation. We're talking about who gets access to a life-saving vaccine first and who gets it second and who gets it next. And I think that's part of the reason why I think every single person who's on this call has a really important role to play in the way that we all are communicating with our constituencies, the way that we are communicating to the communities that we represent and that we speak for and that we're speaking to, right? Because if people feel like, oh, I have to step back in line and someone else is coming ahead of me in line, as opposed to the notion of feeling like, okay, we are at 0 ICU capacity in Southern California, and this, when we think about some of these strategies, this is about making sure that I'm actually a step closer to getting a hospital bed if I need one, right? That is the way that I think that it's hard, because obviously we're all on the call to advocate for the groups that you all are here because you're excellent advocates for the groups that you represent. And at the same time, I think the piece that I want to emphasize is that the way we communicate about this is critically important. It really makes the difference. Communication, especially when still the most powerful tool we have against this vaccine is our behavior. And so I really want to emphasize to everyone on this call how powerful our language, our communication, our framing is when we are reaching out to our constituents and talking about, hey, you know what? We had this conversation. We're looking at, the 65 plus as coming in. And you know what? It's actually not a step back. I mean, listen, it may mean that you get the vaccine later, but here's the benefit to you, right? Because obviously the reason for all of this is for the benefit of all of the 40 million Californians that we all represent.
Totally agree. And that argument about this being a response to the surge and that this is about creating the hospital capacity that we don't know have is, at least in my mind, a really, really strong one, and one that will definitely help make this change, if we do adopt it, something that's a little bit easier for our members to accept. But just wanted to make sure that worker perspective was out there, and that this is something that will be, no matter how we describe it and no matter how good the arguments are in favor of it, is a very difficult thing when you're the one who's, you know, going to work every day, putting your life on the line. More of you are going to get sick, more of you are going to die because of this change. It's a really, really hard thing for a lot of our members.
Thank you. Yeah.
Thank you, Mitch. Okay, we have 3 more comments and then we're going to begin to wrap up the meeting. So let's hear from Matt, and then we'll hear from Orville, and then we'll hear from Sylvia. Matt, go ahead.
Hello, Matt Leger with SEIU California. So I appreciate both the comments that were just made. You know, I'll just say for SEIU has nurses on the ground in LA right now, that moving faster with the vaccine distribution is incredibly important because of the points that Dr. Harris was just making about that there is just not ICU beds. Nurses and healthcare workers are at the breaking point right now. And so moving faster is incredibly important. But I would be remiss if I didn't lift up Mitch's comment as well of the need for a clear process and clear communication. The county by county process is not effective, and it's not a good way for our workers to know when they're going to be in line. And we need to have clear communication of when they're going to be there. That the lack of transparency and lack of knowing that the unknown is causing additional stress on our essential workers who we stood on their shoulders for years, or for this entire pandemic. So just want to make those 2 quick points. So thank you.
Thank you, Matt. Orville?
Yeah, hi everyone, Orville Thomas, California Immigrant Policy Center. You know, really happy, Dr. Burke-Harris, that you talked about communications, because I think that's something that's lacking in these conversations is what is the communication strategy? We keep talking about it every week, but we heard last week about a cultural communication strategy. We continue to talk about how do we message it, and yet every newspaper article I see about confusion starts with a lack of communication strategy. So are we going to hear one from the public health department? Are we hearing it from the governor's office? Because sometimes I feel like we talk in circles and we get it as advocates and we have a limited exposure to the community, but the larger work, the $1 million work needs to be done, and it's not happening.
Thank you, Orville. I will say the work is happening. I want to acknowledge, I think we can do a better job in communicating that to you all and having that be a kind of a clear, unified piece, but the work absolutely is happening, and we can share more about that at the next meeting.
So Sylvia, we're going to go to you, and then Heather Harrison had her hand up and then it disappeared and now she's back. So we're going to, before we finish it. Go ahead, Sylvia.
Thank you, Bobby. And thank you, Dr. Burke-Harris, Dr. Schechter, Dr. Aragon, Dr. Brooks for this, and Bobby as well for calling the meeting. I do think that sometimes that I'm just trying to respond in chat, and in chat I try to be as succinct as possible, and it always looks like some hostile little jab. That really isn't what I intend. So having the chance to speak, I appreciate that. I actually wanted to talk a little bit about sort of some of those intersectional points, and I think sometimes that can be lost. I'm thinking of those the 16 to 64-year-olds with conditions, and I am agreeing with Aaron and Danny and many of the other ones before that it's not just everyone with any possible pre-existing condition. If we look very specifically at those who are receiving home and community-based services, someone is administering those services. This is IHSS workers, often people who are female, people who are of color. It's a group, it's a pair, and those same individuals when maybe working extra hours in nursing homes or with other people with disabilities, and there is a risk of spreading that way as well. It's a real reason to reach this group. Many of the parents who are taking care of their adult children with disabilities are older in that age group, and they might, but they might not be 65 yet, and if they get sick, their children, well, even if they don't get COVID, will also be going to a hospital because they're not getting the care that they should be getting or are used to getting. So there is a lot of intersectionality amongst this entire group. And I also wanted to just sort of raise I appreciate the concerns. I love the framing of that we're trying to keep hospital beds open. I think that's really important as well, and just for all of us to really think through how we can communicate it's the logistics was the final point. I think we really have to think through the logistics at local and county levels, and any help the state can give on that, any kind of, especially around reaching people in their homes and mobility, and having that mobile clinics ready, a plan for that ready and waiting to go is extremely important. I mean, obviously the simplest way to reach people would be first come, first serve, but that seems obviously and clearly inequitable. So thinking through the logistics at this very practical local level has to be done, or all our this discussion of equity is not going to achieve it.
Thank you, Sylvia. Heather Harrison, you're going to get the last word here.
Hi, thanks. And I'll be quick. I want to thank everybody. I really appreciate this conversation. What a monumental task this is. It's exciting to see the conversations move to the further phases and tiers. At the same time, the tier that we've been in for a while now, 1A, has assisted living residents and staff. Still, the bulk of those communities, the vast majority, still waiting for their clinics. Really hoping that some of the conversations today that we heard about at marshaling these additional resources directed to this setting is reassuring. So it was very good to hear that. I appreciate it. Our residents and families appreciate it. Also wanted to echo the call for clarity. One of the things we hear from our residents and their families and our workers that gets confusing is when counties announce that they're moving on with big clinics for 1B and for other settings, but they don't have a date for their shots yet. And that's one thing that we would like to be a better partner with the state to help carry that message and communicate so that our residents and families and workers know what to expect.
Thank you, Heather. Very well. Okay, Dr. Burke-Harris, back to you.
Well, thank you so much. And I want to thank everyone for making the time urgently in your schedule for this meeting. All but 3 members attended today. So again, you all are just demonstrating your commitment to this work, and we are very grateful for your input. I think what I want to reflect back what I've heard in this conversation, and there were a couple of major themes. I didn't get through reading absolutely everything in the chat, but I know that Bobby will print it out so that I can, so that we can read it, because it was a lot. It was a vibrant conversation. But the big thing that I heard was, hey, don't forget about all the things that we've been talking about in all our meetings so far, right? Don't forget about how important it is for us to be prioritizing equity, for us to be doing strong implementation for our vulnerable seniors and those who are in long-term care, skilled nursing facilities, and other types of facilities. Don't forget about our folks who are in congregate settings, such as shelters or who are incarcerated. And I want to emphasize, and I want to just hold for folks that we are not forgetting about those things. And as we are thinking, and we won't, and we're grateful for your strong reminder that these are key priorities as we are moving forward in this work, and we hold those as priorities. And really, as we're looking forward, as we're planning forward, and as we're responding to the surge and the data and the information that we are getting about who is most vulnerable and what is putting our healthcare system at greatest risk, right? We're also hearing that those resources need to be put in place to make sure that we are effectively vaccinating those who are in phase 1A, to make sure that we are effectively implementing some systems with a thought towards equity, and that this is, and we heard it, this is hard work. This is sometimes challenging, complicated work. And we recognize that and are not losing sight of the logistical work that it takes to reach hard to reach populations. We also understand and are hearing that for, as we're responding to the public health emergency and the challenges that we're facing in terms of thinking about prioritizing individuals 65 plus in phase 1B, that it's also critical for us to recognize and think about how we're doing our messaging, how we're communicating that to others, and that a key part of maintaining that trust and that communication is some thoughtfully the thoughtful and clear rollout of the current plans that we have in place. And finally, I want to add this notion of a question about how we can be more specific in looking at those who are 16 to 64 who do have health conditions that put them at increased risk for severe COVID-19 disease, and whether or not we can take another look to understand more precisely what that number of individuals is, and whether or not that number of individuals is as large as the estimate that we are concerned about or that we're using in our decision making. And so all of that we will take back and bring to the Vaccine Advisory Committee, bring that to for the purposes of decision making in the governor's office. And with that, I want to thank everyone for your time. I appreciate all of this input. It's incredibly valuable to us, and we look forward. The next meeting is going to be on January 20th from 3 to 6 p.m. And so we look forward to seeing you all. I believe that's next Thursday, if I've got it right. Next Wednesday. Sorry, I don't have my calendar in front of me. Next Wednesday, and then the next couple of meetings after that are February 3rd and February 17th. Very grateful for all of you for your responsiveness as we're responding to this emerging issue, and grateful for your input.
Thank you, everyone. The meeting is adjourned, and we are so appreciative that you all made time today to be with us. And we will see each other next Wednesday, and we'll continue this conversation. Thanks, everyone.
Thank you.
Thank you.
Thank
you.
Bye. Thank you.